Hello and welcome to the March episode of the IJA podcast. This is me, Gayatri.
And me, Rashmi. And we're back with another exciting episode.
Now, without wasting much time, let us keep up with our tradition of opening the session with none other than our Editor-in-Chief, Dr. Rakesh Garg. Dr. Rakesh, welcome to the podcast.
Thank you, madam, and thank you to IJA podcast team, Dr. Gayatri, Dr. Rashmi, and Dr. Murli.
So how have you been, sir?
All good. I think with the help of all the readers, reviewers, authors, I think IJA is flourishing, and so am I.
I see that the heat has not slowed you down one bit, and you're already out with the April issue of the journal.
Absolutely. I think with the support of all the authors and reviewers and with my editorial board, we are on time and we are before time, in fact, so that our authors get all the benefits.
Hi, Dr. Rakesh. Could you quickly tell us about the March issue of the edition?
Yeah, so March issue of edition is bringing many interesting articles. There are quite a good number of original articles with few case reports in the form of letter to editors also. And as usual, IJA is covering all the domains of perioperative care in anesthesiology field. And there are component of many of the component of hemodynamics and regional anesthesia which are coming up here. And these definitely would be boosting to bring better patient outcome. And I'm sure this will be helping our clinicians who will read these articles and incorporate into clinical practice for the betterment of our patients.
Yes, absolutely, Dr. Rakesh. Thank you so much. And so for this month, Dr. Rakesh, we have lined up articles for the author interview segment. And one of them is a non-inferiority trial from a group of authors from your institute. So recently, the February issue of the British Journal of Anaesthesia had a beautiful editorial by Shantana and Joshi, which gives very good details of concept and understanding of non-inferiority trials. So I wanted to ask you, do you approach non-inferiority trials with some amount of skepticism when such a manuscript is submitted to the journal?
I think interesting question because this always has been an issue when some authors submit their non-inferiority trial to a journal or they plan to conduct it. They are usually issues because we are looking for something new which is superior. So why do we want to have a thing which is maybe non-inferior to the existing things? But yes, I don't think it's skeptic about the non-inferiority trial. What we need to look for is that what actually has been studied. So if I just put it in a very big, broader perspective, so if I have a drug or I have a technique which is relatively new from my experience, and I'm comparing with some existing treatment, I'm saying that it's not worse than the existing treatment. But when we say a study, we are looking for a primary outcome, which is the main outcome, and which is not worse. But then if it gives an advantage to our clinicians in certain aspect, maybe say, for example, side effect, maybe say if I put at a regional block, if the success rates are better with less amount of volume, with less amount of toxicity, less amount of time taken. So I think non-inferiority trial, if there is a justification for it, so I don't think we should not accept it for publication. And as you rightly mentioned, these type of trials are coming up into various publications across the world. Only thing is, when these trials are published, the author should be well versed with the concept of non-inferiority trial. And that is what is required. Sometimes we say that the new treatment is not worse than the conventional or standard treatment. But if we don't assume the statistical aspect appropriately, if we don't conduct the study properly, probably the acceptance will be poor. So it is the conduct of a study and the justification that will make the trial based on non-inferiority concept will be acceptable.
Okay, all right. Thank you so much, Dr. Garg. Rashmi is going to now talk to the author concerned.
Coming to our first article, which is comparison of the effects of dexmedetomidine and nitroglycerine on cerebral oxygen saturation using near-infrared spectroscopy in patients undergoing controlled hypotensive anesthesia. To talk about this article, I welcome Dr. Swati Chabra from All India Institute of Medical Sciences, Jodhpur. Welcome, ma'am.
Yeah, thank you, and hello, everyone. I'm happy to be here on this podcast, communicating with the readers and the persons from the journal itself. And when given this opportunity, I immediately grabbed it, and now I'm speaking on behalf of the team.
Doctor, what motivated your team to investigate the effects of dexmedetomidine and nitroglycerin on cerebral oxygen saturation during controlled hypotensive anesthesia?
The beginning point was when we were observing that we do a lots of surgeries where controlled hypotensive anesthesia is required, where we are inducing hypotension in a deliberate but controlled manner. So we just wanted to see that whether achieving a particular target of blood pressure, which is like mean arterial pressure, the way we did, or there are like numerous definitions. What happens to the brain? We are always saying, okay, hypertension should be treated, but here we are inducing. So we just wanted to study the cerebral effects, and the non-invasive monitor we have in our hands is near infrared spectroscopy, which gives us regional saturation of oxygen in the cerebrum, in the frontal area. So we went ahead with that to see the cerebral effects if it has any.
Right. Doctor, could you explain the rationale behind choosing this a non-inferiority trial design for comparing these two interventions?
Yeah, so as Dr. Rakesh Garg had said in the beginning, that
Right.
when we already have a treatment which is already existing, and then we have to compare it with something. So, first of all, the drugs which came to our mind was nitroglycerin, which is like conventionally everyone has been like using it. It
Yes.
has become an informal drug of choice for hypotensive anesthesia, and the Dexmed is the new rage. Everyone is using Dexmed wherever it is possible. So we were looking at these two drugs and the method of trial. Okay, now we say we have NTG, which is like a drug of choice, Dexmed new. So let's see if at least this approach is, or if it is as good as nitroglycerin and at least doesn't cause any harm. So looking at this, after enough brainstorming, we decided on a non-inferiority trial design.
How did you measure the
Yeah.
cerebral oxygen saturation using near-infrared spectroscopy? And what were the primary endpoints used to assess this non-inferiority between Dexmed and nitroglycerin?
Yeah, so we have this monitor which comes with electrodes near infrared spectroscopy, which are applied on the forehead on the left and right side. So it gives us our SCO2, which is regional cerebral oxygen saturation, separately for the left and right side. It is regional, not global, but still it gives a value. We use this to measure the cerebral oxygen saturation. And for our primary endpoint, we used a number of cerebral desaturation events. So those events we labeled as 10% desaturation, 20 or 30% while we were observing it. We didn't go for cerebral oxygenation values, the SCO2, because these are very variable values. The baseline also varies between individual to individual. So it is a trend monitor. So we just see how many desaturation events occur in each group, and then we compare them.
Okay, doctor. Were there any unexpected challenges encountered during the trial, particularly regarding the patient's response or safety profiles of the interventions?
Surprisingly, when we explain patients are very skeptical when it comes to, coming under scanner or being a part of the research study, especially
Yes.
who know that they might be studied. It could be different from the normal care. So, but surprisingly, in this during this study, what our team encountered was when we explained that we are going to use hypotensive anesthesia, which is a standard of care, so that you don't bleed much. There is, a better surgical outcome. So that is what we are using as a point of as a standard of care. Additionally, we'll be monitoring your, oxygen in your brain. That is what the layman terms we used, and they were happy. Okay, if the hypertension is going to be there to a controlled degree, at least our brain is being measured for any decrease in, perfusion or blood supply or oxygen, whatever they would understand. So there was no challenge per se on the parts of the patients end. The challenge per se was putting in some of these cases as routine use, we would not put an arterial line, but to standardize the anesthesia care here, and we were using nitroglycerin or dexmed. So it was blinded, so we didn't know which patient gets what. So we put arterial line. So somehow that was a challenge when surgeons had to wait for another 5 to 10 minutes to get that arterial line in place. Otherwise, it was a smooth sail. Yeah.
So constraint-wise. Considering the results of your study, how do you foresee the potential clinical implications for anesthesia management strategies in patients undergoing procedures requiring controlled hypotension?
I would say this is a step towards, monitoring the cerebral effects. All our anesthetic agents or other vasoactive agents which we use during anesthesia have cerebral effects. And if we are monitoring the cerebral effects using a monitor, then it is a first step in this domain of controlled hypotensive anesthesia. There is a limited literature, of course, not being routinely used. There is some cost involved of the electrodes. But if it adds to safety, there is less cerebral desaturation events, and maybe we can go further down in a particular, not follow a particular target in future, like 50 to 55 of mean arterial pressure. In certain patients, if there is desaturation, we can keep up to 65. In some subset, we can go to 45, 50. So if we use this as a monitor, who knows? We have this individualized pressure targets for controlled hypotensive anesthesia. That's for in the future to see.
Thank you, Dr. Swati, for clearing majority of the doubts regarding the article. Next, we have an article which is based on comparative evaluation of continuous infusion versus programmed intermittent bolus techniques in erector spinae plain block in modified radical mastectomy, a preliminary randomized control trial. To discuss this article, we have Dr. Dibesh Boy from AIMS, New Delhi. So what led you to investigate the comparison between continuous infusion and programmed intermittent bolus techniques?
First of all, thank you very much for the invitations, and thank you to all the panelists, Dr. Rakesh Kar and all, so giving the opportunity to talk about the article and also the thought process behind basically this randomized control trial. So as you all know, the erector spinae block after its evolvement has been gone through a tremendous utilization of this block in variety of surgeries, starting from in all sort of fields, starting from the erector spinae, the level of block, if stay the cervical to the sacrum area. So in my practice, when I started using this block, initially the single shot plain block in this cardiac surgery and also the general breast surgeries and all. So what I saw is that whenever there's a plain block, you're giving a drug at a certain point of time. So the plain block has a tendency that if you're giving a bolus at a certain pressure, basically, even specifically considered the erector spinae muscles, it is a huge muscle in the paraspinal back muscles. So if you give a bolus drug, it has a tendency to spread and cover the white area. So that gives the analgesia, basically. And if you see the traditional, normally, whenever you are doing putting catheter or something, so normally we use a continuous method. That is traditionally we use that. But that might be right for a neuraxial, or suppose a neuraxial block or something like a thoracic epidural you are putting, or suppose a peripheral nerve block, because the space, there's a definite space, you have created a space, and then you will continue the drug. So it might be separate or surrounding the nerve itself. When you consider a plane, basically, if you are putting the resistance, basically, that is just too much. So if you are not putting in the volume under certain pressure, the drug is not going to spread. So what you will land up in doing is that the drug is going to deposit at certain level only. So what your main purpose is not going to solve. So if you see in a modified radical mastectomy or a thoracic surgery, if you see you need a drug that's spread from T2 to T6 or a T4 to T8, so you might need a level that is around up around 10 or 10 centimeter. So in that case, in this case, I thought that if you're putting a catheter, let us see, because single shot you have seen, continuous traditional practice, you do a infusion. Initially also you have done that 5 ml per hour or 4 ml per hour. That is also not standardized what volume exactly you do. So that's why I planned this study. Let us give the same volume that normally in practice we give a 5 ml per hour, suppose. So let us give the same convert into a bolus form. So normally we give a 20 ml of drug in the bolus form as a electrospinal block. So let us convert into continuous versus intermittent. And also the literature support at the time when you started, because it is a preliminary, as I said, I gave a thesis to this candidate. So when I started the thesis, because of my experience in electrospinal block, so at that time, the literature was scarce in the official plain block. Basically, whatever the study was there, it was continuous. And also the intermittent, and this comparison was basically the Dr. Jonathan et al. Studies. They also concluded that there is no any definitive conclusion based on this, because at that point of time, the literature was not supportive or not enough to conclude one thing. So we thought that's to go on the study, and that's why it is a preliminary study also, if you say.
Okay, doctor. So how did you design this randomization process for your trial, and what factors did you consider when determining the sample size?
Yes, the sample size calculation is always challenges. There is 2-3 factors that normally you have to consider. In this case, as you said, as I started this project as a thesis for a student, that is a 2-year course, we have to finish it off. Then again, the constraint of sometimes the continuous catheter you might not get. So the other limitation that normally we had. But regarding the sample size, we take care that it's a preliminary study. So at least rather than a big pilot, suppose a number of sample, at least you can take a 25 to 30 sample, because you don't have at that time effect size to decide on which is superior or which is inferior. So in that case, we didn't have any proper study to say it is, because we same thing from a peripheral nerve block or a perimeter block, we cannot extrapolate the same effect in a facial plaque block. So at that time, the literature is scarce to say anything so that you can define a good sample from based on the effect size. So that's why we planned for a initial pilot, so that you will go for your sample of convenience, though it is not accepted as a good EA, but still it's a level of convenience we took, so that by the 1 year, 2 years, we can finish up at least 25 to 30 in each group at least, so that there will be a big effect size and you can have a conclusion, so that the future study can be planned on that. And your results are exactly, we found the same, and we had a good result with that.
Right. Doctor, could you elaborate on the primary outcome measures used in your study to assess the efficacy and safety of each technique?
Again, as I know, there's a planning a such type of study and the safety and efficacy of this. If you per se any analgesia technique, normally we consider in this case same also. So normally 2-3 things we take into consider. Whether if you are giving any block or any new technique for analgesia purpose you are considering, you must ensure that if the new technique is going to decrease any sort of opioid consumptions. Because overall you are trying to just decrease the opioid consumption by any means, so that the opioid related side effect will be less. At the same time, also consider based on this modified radical mastectomy cancer surgery, so that the opioid reduction will have some sort of avoid immune response, immune related things, so that the patient will not go into the recurrence on those things. That is those are factors. Second is that the consumption per se is just over a period of time, so the 6 hour, 12 hour, 24 hour. So by considering that we have that 24-hour opioid consumption in each group, at least we can have a good idea. Then we can see that over a period of 24 hours, how much opioid consumption basically consumed by each group, so that you can tell that opioid consumption is less in certain group or they're superior in terms of opioid consumption from another one. Second is that another thing also we took into consider is that even if it is decreased the opioid consumption, that is effective, or it is display, or it is again replayed in terms of quality of recovery or not. Because if you consider all the things regarding the quality of recovery and considering the pain, consider the PONV, this is basically collectively. So that's why I thought that any technique that is going to improve the quality of recovery, that should be selected as a choice of analgesia technique. So based on this, we took as a opioid consumption, and also the secondary outcome that we take as whether pain control is good or not, PONB, and the quality of recovery. And along with that, some of the observation that because we are giving a bolus dose every 4 hours, we want to see any sort of more complication or catheter dislodgement or any possibility of discontinuing of the treatment. Those are the things, any significant hypotension. So these are the observations that we keep in mind, those things.
Doctor, did you encounter any unexpected challenges during the trial, and how did you address them?
Yes, if you say the challenges, obviously we had challenges, we faced challenges because when you started as a single shot, first thing to put a catheter in a modified radical mastectomy surgery, that surgeon is not keen on. Sometimes if you see in a routine practice, they don't allow a block, sometimes regional block. That way I've convinced the surgeon is to put a single shot, and that way I also see, because modified radical mastectomy, I show them the modified radical mastectomy is a major surgery that has a tendency, has a pain. You don't know how much opioid consume he will consume and the quality of recovery, whether it's mobilizing or not, pain-free, hand movement. There's also other implication. So the first thing to challenge is to convince the surgeon for putting a catheter based on the expertise and also our efficiency in doing the block previously in the single shot and other block in the same surgeons, because we consider the same surgeon that routinely we're doing. So that is the most important thing. So he had a faith on us. So we convinced that you can put a catheter that is not going to affect the surgical time, because we planned the study in such a way that we are going to put the catheter in the pre-operative period. So if you counsel the patient properly position the patient, we give some, we require the patient sometimes some sort of anxiolytic, then obviously good amount of local anesthesia if you give, you can easily put a catheter under sedation or under in the pre-anesthesia room under monitoring conditions. So that is must. So at least this took over the surgical time or any interference in the surgical time. This is the first challenge we can encounter. Second thing is that putting a catheter, sometimes if you know availability of the catheter, that is normal in routine practice, we put a epidural catheter. If you're not having a continuous contiplex or like that. So at that time, we institute didn't have that. So we had to depend on a epidural catheter putting it. So erectospinal plane block, there is a different challenge. When you did the block initially, that you face the challenge. See there, once you give the bolus drug, normally the plane collapses. So normally in a peripheral nerve block or something, once you give a bolus drug, the space remain open for a certain time so that it will give to disconnect the epidural catheter, put the connection, then put the catheter. So in erectospiny, that doesn't give time. Suppose you give the bolus, by the time you take out the catheter, then railroad the catheter, by the time your plane will be collapsed. So you may not be able to introduce your catheter smoothly. So to avoid that challenges, we innovate some techniques. Basically, that same thing also we published in the other journal. So we put a central line that is 3-way catheter. Basically, we see the normal central, the needle has the 3-way or the Y connector. So with the Y connector, we take that and it attached to the epidural catheter. So in all our cases, what you do is that we initially the catheter was placed inside the epidural needle, and the side port was accessed to the drug port that was used as a drug port. So basically, the catheter is what already railroaded in the epidural catheter till the tip of the needle. So once we put touch the transverse process and give the bolus drug by the side port, the catheter is just right there at the tip. So the moment the plane is open up, we just slide the catheter. So we didn't have any loss of time. So that means it occurs more smoothly and simultaneously. So basically that Y connector, use a Y connector that gives us face the challenges, and we solved it so that all the cases were done very smoothly in that case. This is the second thing. Another thing that normally is that once you put a catheter, in this case, another important thing is to consider is that when you're putting a catheter, because you are comparing a continuous versus an intermittent bolus, you have to make sure that your placement of catheter should be same in both the cases. So under ultrasound, seeing a catheter at the exact location is another challenge, because the normal epidural catheter is not sonoplex here. So that means you may not be able to see the catheter properly because it doesn't have that here. So what we did is that during that position, you use the air contrast. So that means we are doing that with putting the catheter the final position, we maintain a negative aspiration so that the air bubbles will be inside the catheter. So that gives an idea that where exactly your tips are. So that helps us to put exact location of the catheter, and that was done in all the cases. So the same images also will upload in that. And this concept also published in the journal. So because of these two challenges, we had the challenges, we faced it, and we all solved it, and also it come out successfully. So these are the challenges that normally we have.
Thank you, Dr. Devesh. That was really interesting how you encountered all your challenges.
Thank you.
Doctor, how do you envision the results of your study impacting clinical practice or any future research in regional anesthesia for mastectomy procedures?
Yes, if you from the result of a study, if you see the mastectomy surgery, obviously there is a lot of surgery that's starting from a simple mastectomy or lumpectomy to the modified radical mastectomy. So if you are planning for an extensive surgery like a modified radical mastectomy, we can see if you are planning for a catheter, at least the continuous infusion, I will not recommend this continuous infusion. It is always ideal to put a catheter, and if you are putting a catheter, but again, the debate is something else because versus singles versus with continuous but if you compare as a continuous versus intermittent, I must say that if it is a major surgery and putting a catheter, it's better to give a intermittent bolus technique. Any facial plane, ideally the volume should be given as a bolus so that it will involve as a more and more in area at the same time, at the certain interval of time.
Thank you, Dr. Debesh.
Thank you.
As we conclude today's podcast, I want to express my gratitude to our guest speakers for sharing their valuable insights and expertise. We hope that our listeners have found this episode informative and engaging. So stay tuned for much more insightful conversations and interviews on our IJA podcast, where we continue to explore our latest developments. So until next time, thank you for tuning in. Keep listening, keep growing, and keep making a difference in your profession. Thank you all.